Epileptics and anticoagulants mostly हाम्रोमा stroke पछि आउने भएको कारणले we are doing this. So यो चाहिँ basic algorithm for stroke case emergency मा आउँदा के गर्ने भनेर mostly stroke हुने stroke को typical symptoms देखिने बित्तिकै त्यो CT to rule out hemorrhage छ कि छैन so that hemorrhage रहेछ भने त्यो अनुसारको प्रोटोकलमा जाने भयो ischemic छ भने त्यही अनुसारको सो यो अनुसार चाहिँ ischemic छ TIA मात्र हो भने के पनि नगर्ने observation जस्ट लाइक हिजोको दाइको केस हो कि भन्ने छ अरु भनेको चाहिँ तपाईको हार्ट कार्डियक छ कि छैन रुल आउट गर्ने अनि if cardiac cause छैन भने then we can go on with meds if there is cardiac cause then we can do a lot of other things like thyroid test and echocardiogram and if echo is okay then we can go with treatment but if not then we can start in warfarin. We recently had a few cases who had heart trouble, mechanical valve so they were in warfarin. So they were two were very young and one was an old lady. For drugs we use aspirin mostly. In Nepal we have seen aspirin and clopid. Paracetamol चाहिँ त्यति सारो हाम्रो पेशेन्ट आउँदाखेरि चाहिँ त्यस्तो देखिएको छैन. So we can also do low cholesterol drugs, lower cholesterol drugs which also helps prevention of further CVA in future. So first I'll do about anti-epileptics. So what happens is in a lot of cases the seizures in stroke are more likely to be partial and if there is late onset of seizures it is more likely to be generalized and very few cases goes into status epilepticus because in further time period it gets resolved. But if the onset is late, they might need a very prolonged treatment of anti-epileptics. So in epidemiology, most of the cases, mostly in hemorrhagic case, there is presence of seizure. In total, 8.9 to 9% of cases present with seizures in stroke, 10.6 in hemorrhagic and 8.6 in ischemic stroke. So in these cases, reoccurrence is 2 to 3% in cases. So if the lobes involved are multiple or is in cortical region, then there is higher chance of incidence of stroke, seizures. So we have this two classification where because of time period, like if the onset is as early within 2 weeks, then it's called early post-stroke seizures and late post-stroke seizures. How does the seizures occur in ischemic cases? So there is two strokes, ischemic and hemorrhagic, so they have their own mechanism. So in ischemic stroke, the hemodynamic, mostly the electrolytes like sodium, calcium, they get collected because of the infarction, so which will cause the metabolic disturbances and cause the stroke. In case of hemorrhagic stroke, there is the production of hemosiderin from the blood collection in brain, which will irritate the brain and cause seizures. In this case, if there is no stroke, patient comes with, if there is no seizure but patient comes with a stroke, there is no need of medications. But if there is stroke at the presentation, then we provide anti-epileptic drugs as soon as possible so that it may prevent the further other complications. But there might not be need of long-term AED. So monotherapy is sufficient. So in case of mostly in our scenario, we have seen using Phenytoin in seizure cases, or if there is hemorrhage to prevent seizures, they use Phenytoin. And if there is if it is not possible to wait for Phenytoin and other, then we use midazolam, diazepam, or if there is case of intubation, so we use these drugs. Commonly, carbamazepine, phenytoin, and sodium valproate were the first choice, but with the improvement in drugs and recent stories, lamotrigine and levetiracetam are preferred now, and they are a bit costlier than the earlier drugs. They are preferred because of higher rate of long-term seizure-free period, fewer interaction with other drugs, especially anticoagulants, which we use with them in ischemic Cva. Also, we had a case in our ward who had phenytoin reaction. So it was very bad reaction. He was in prolonged phenytoin treatment. So mostly the CVAs are caused because of heart conditions. If there is, in this study, we can see acute left ventricular thrombus. The thrombus and emboli that are lost from heart, they go to brain and cause the stroke. And we also had like 3 cases. We had mechanical valve. They presented with stroke. Here, so what do we do? Okay, if I did that. So this up to here it's anti-epileptics. Now I'm starting anticoagulants. So in anticoagulants we saw the algorithm. So we use aspirin as soon as possible, but because of advanced technology nowadays, thrombolysis are present everywhere. Even in Pokhara we can do it in Manipal, but we need the case to be on time, to be presented in ER on time. Mostly they say 3 to 4.5, but sometimes looking at the scenario they even do 6 hours. And atiplase and tenecteplase are used in Pokhara. So if there is large cerebral infarction, hemicraniectomy is advised because of the mass effect. And these are other drugs used for the secondary prevention of stroke. So what are the inclusion criteria for thrombolysis? If it is acute, so we have to do CT to rule out if there is any hemorrhage or not. If there is no hemorrhage, then we can go on with thrombolysis. It has to be less than 3, or they say 4.5. There should be no CT evidence of hemorrhage. There should be no history of anticoagulants use, like in cardiac diseases, they prolong anticoagulants. The age should be more than 18, and there should be informed consent. And these are the exclusion criteria. So there should not be any history of trauma. There should not be recent major surgeries. We should rule out there is, if any, aneurysm or hemorrhages in CT scan. We can look for vitals, and the BP should not be more than 180 and diastolic 110. The platelet count should be at least 1 lakh, and the patient should not be pregnant, and the INR should not be more than 1.7. So when do we do thrombolysis? It should be done as soon as possible if after we rule out hemorrhage. So we give 0.9 mg per kg. We give 10% at the time of presentation and over 60 minutes. So thrombolysis is very the best thing to do to have a better outcome, but it might exacerbate or cause hemorrhagic transformation, so we have to observe for it. These are ischemic Cva. So in this picture we can see where and how much the area is involved. So in the first picture we can see it's a very minor, less than 1.5, moderate and severe, and there is this in circle. This is the midbrain part. So these categorizes so we can know when to start drugs. It will help us determine the time period, because we say, oh, ischemic stroke, we can start aspirin, we can treat patient and prevent further ischemic stroke in future, but according to study we have to wait for the time when to start, when is the better time to start, and what kind of CVA needs quick anticoagulants and which should we wait and observe. So because if we start anticoagulants sooner, there might be chance of hemorrhagic stroke. But if we don't start, there might be chance of re-ischemic stroke. So we have to balance that. For this, in this picture, after doing CT, and if we say like it is ischemic stroke, then we have to do MRI. So we can, in this DWI picture, there is the first picture, there is no any changes. So it is TIA, and we also see the film GRE. With these two films, it helps us to decide if we can start aspirin or any other antiplatelet anticoagulants sooner or later. Here in first picture, it's DWI negative and the GRE is negative. So there is less chance of hemorrhagic transformation. So we can start as soon as possible. We can give aspirin and carry on with it. But in here, in minor case, if it is there is less than 1.5 centimeter, and if it is GRE negative, we can give anticoagulants less than 48 hours. But if it is asymptomatic and there is a small hemorrhagic transformation, we should at least wait for 48 to 96 hours. So if we see CT is normal, but in MRI we see moderate hemorrhagic transformation, and if it is asymptomatic, we can do it in 48 to 96 hours, so that it will not turn into hemorrhagic stroke. So if in case of severe and if there is symptoms, we might need to wait for 7 to 14 or more than 14 days, seeing how much the lobe or the brain is affected. So in anticoagulants, here we use heparin infusion. Apixaban we haven't seen much. We mostly see warfarin if there is cardiac cause. Aspirin and clopidogrel are mainly seen. We can give heparin, but we have to absorb. So mostly in acute cases or in hospital setting, they give heparin, but when the patients are discharged, we use mostly aspirin and clopidogrel for long-term use. So these are the doses. For loading dose, like we saw the MRI, and if we want to give, we can give 300 mg stat, and then start 75 mg once a day. But if there is like treatment, we gave thrombolysis, then we can wait up to 24 hours, then only we can start aspirin. And clopidogrel loading dose 300 and then maintenance dose 75 mg. So clopid is more better in form because it does not cause as much as hemorrhagic transformation. Also because aspirin causes GI symptoms in long-term use, and the patient has to take it for a longer time. So somewhere they give clopid, and somewhere seeing like if the patient is old, if they have like gastric trouble previously, then we can choose clopid. We can do our like decision saying the case. Thank you.